any use for chemoimmunotherapy other than FCR for young, fit, mutated IGHV patients. People are still using BR, they're still using chlorambucil, obinutuzumab. I know what the answer to this question, or I know what I think the answer to this question is, but I think it's important for people in the community who are seeing these patients to hear what is the role for chemoimmunotherapy other than the specific example you gave about FCR?
Well, so I think for me, BR has little role in the upfront setting, if any. And the rationale there is that in the group that we really think benefits from FCR that I've described, we do not know that BR achieves the same benefits. So I would not be using BR in that group. And then really for everyone else, we have data, say from the Alliance study that ibrutinib achieves better progression-free survival. And so I see less of a role for BR as the initial therapy. Likewise, chlorambucil and obinutuzumab has lost now in several trials to BTK inhibitors and to venetoclax obinutuzumab. And so is there a role? If I play the devil's advocate for a minute, I will say that none of those treatments improved survival compared with BR or with obinutuzumab chlorambucil. And so one can certainly make an argument that it's acceptable to start either of those chemoimmunotherapy combinations and then bring in the targeted agents later if for some reason you were to want to do that. It's just not putting your best foot forward. So for me, there's very little role for chemoimmunotherapy as initial therapy other than what I've described in the young fit patients.
Dr. Allen, a similar situation for you. Do you really base it on an individualized decision and have the patient's input into the selection for first-line therapy as your major strategy?
Yeah, I mean, I think 5 years ago when ibrutinib was coming out, the decision making was relatively easy. This conversation with our patients was relatively straightforward. It was, here's the data with chemo, here's the emerging data with this BTK inhibitor, here's the toxicity differences. And really when I had that conversation, I like to make decisions with my patients. I don't typically, make the decision for them type of situation. And so I try to inform them as best I can. And really, depending on how you kind of spin it, you can really make any approach attractive. Ultimately, in my belief, I think these novel therapies are the way to go. I think you spare a lot of toxicity, you spare a lot of potential long-term toxicity, and essentially this conversation, has now become very complicated and long, to where you do talk about when you have that really low-risk patient that has been presented where they might benefit long-term from FCR. Now we've got good data with ibrutinib long-term head-to-head, and now we also have venetoclax obinutuzumab, which also provides the attractive part of FCR, which is a fixed duration and potentially long-term benefit. And so now this conversation with my patients has become a relatively simpler 20-30 minute conversation to at least an hour-long conversation when you're talking about an initiation of treatment and all of the potential options to inform them of what it is. And our patients, our heads are spinning at the end of it, and they need another week or two to kind of think about it, to come back about what's right for them. So I echo all of these issues that we're facing, and I do think the future for us is moving towards these ibrutinib-based or BTK-based and venetoclax BCL2 inhibitor-based treatments. And I think really as time goes on, we're going to find the right patient for which drug. We just don't know what that is, and we'll find that subgroup. We'll be able to identify the best patient, and therefore our decision making will be a little bit clearer and easier with true data behind it, and we'll be a little bit more confident when we say a decision, for a fixed duration or continual therapy and things like that. So, still patient factors come into it. And I just throw it out on the table, and I'm like, hey, these are the options. They sometimes ask me what I would do. I kind of give them my opinion, but for the most part, I found our CLL patients are very educated. Obviously, they're very informed about all these options, and they kind of know what they want a little bit coming into it as well.